Welcome to the latest MS Hear from the Experts webinar. These webinars help people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate their MS journey with more knowledge and confidence. Thank you for joining us for today's webinar. My name is Shauna McKinnon, and I'm your moderator for today's broadcast. I was diagnosed with MS in 1998 and have been a volunteer with the MS Society and now MS Canada since that time. MS Canada would like to acknowledge that we are on the ancestral territory of First Nations, Inuit, and Tea people across Canada. Nations have cared for this land from the oceans to the mountain peaks for the thousands of years and continue to do so today. We thank them for their continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land that we all call home. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. Your microphones have been muted. If you have a question, you can type it into the chat box and we will try to get to as many questions as possible following the presentation. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. This session is being recorded and will be available soon on our website from the Informative Videos on MS page. A Facebook Live recording will be available as well. Please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but instead provides information to assist individuals in making their own health and wellness decisions. Plus, the views and opinions expressed in this presentation are those of the speakers and may not necessarily reflect the views or positions of MS Canada. Since 1948, we at MS Canada have been proud to be a part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we have helped fund research, provide information and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate, so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Please note that during this broadcast, a couple of pop-up polls will appear. We ask that you respond to each. The anonymous information will help MS Canada better understand your experience and the impact we are having on the MS community. Today's first expert is Trudy Campbell. Trudy is a nurse practitioner of neurology with the MS Clinic at the Queen Elizabeth II Health Sciences Centre and an adjunct professor at Dalhousie University School of Nursing in Halifax. She graduated with her undergraduate degree in nursing from University of Prince Edward Island, then went on to receive her Master of Nursing from Dalhousie University. She is a member of the Consortium of MS Centers and the International Organization of MS Nurses. Trudy is a multiple sclerosis certified nurse, plus a certified holistic nurse coach and consultant. She has over 20 years of experience as a nurse practitioner in MS care. She is actively involved with research and has collaborated on several research studies, plus co-authored several peer-reviewed papers. Welcome, Trudy.
I'm not sure that it's me that they're speaking of when they introduce me, but nonetheless, I want to welcome everyone this evening and thank MS Canada for inviting me to speak with you this evening on understanding pain. When we think about pain in MS, there are two kinds of pain. The acute pain, a pain that occurs suddenly, and generally is short-lasting, maybe less than 3 months, and often less than that. We think of acute pain being more similar to an injury or something specific with a very obvious cause and effect. And I'll talk more about that later. Most of the conversation this evening I'm going to speak about is about chronic pain. Oh. Excellent. Someone has taken control of my slides. Thank you. So chronic pain, what do we know about chronic pain in Canada? We know that it affects about 8 million Canadians, or 1 in 5. Chronic pain is pain that occurs. It may come on as a neurological cause of pain or other type of pain, but lasts for more than 3 months. The economic burden of chronic pain is about 40 million. Pain is a symptom of many conditions, including MS, but not limited to MS. And what we know is that persons who live with MS can experience pain related to their MS, but can have other conditions that can also cause pain. And that becomes relevant in terms of how we understand a person's experience with pain, but also how we go about recommending treatments and supporting a treatment journey. Pain in itself can be considered an illness, and we know that pain is impacted by genetics, by lifestyle factors, by comorbidities, or the number of illnesses a person may have. Pain is impacted by age and also by sex at birth. We know that pain affects females more than males. And we also know through some research that has been done here in Canada that pain affects Indigenous persons more than non-Indigenous Canadians. When we look at types of pain, there are 3 categories where we try to divide pain in ways to understand it, to describe it, and ultimately to offer recommendations for treatment. There is neuropathic pain. This is pain that is related to an injury to the central nervous system, so the brain or spinal cord, or injury to the peripheral nervous system, so the smaller nerves throughout the body. This type of pain often is described as a burning pain. It can be shocking or shooting, stinging, stabbing, sometimes described as a throbbing, and often has a tingling quality. Some people describe it to me as a feeling that their foot may be asleep and is just starting to wake up, that sort of half numb, half tingly, uncomfortable feeling. The other type of pain that's quite common is nociceptive pain. This is a tissue inflammation. It is generally as a result of a direct response to an injury. So you fall, you break a bone, maybe you hit your finger with the hammer or jam it in the door, and that is an obvious something happened, pain is a result. It can be obviously sharp. It can be aching, throbbing in a period of recovery, but generally this type of pain will have an obvious cause. Nociplastic pain is more of a combined pain, a combined neurologic and tissue pain. There is often no cause for injury that can be acutely identified, and generally speaking, this type of pain is more widespread. Often with it comes disturbances of sleep, of memory, mood and anxiety, as well as fatigue. Next slide. So when I started my career in MS care, one of the things that I had heard was that pain was a symptom of MS, which is not surprising. However, I continue to hear on a regular basis that people maybe who have been recently diagnosed with MS or who have been living with MS for a long time have been told that pain is not a symptom of their MS. Well, what do we know about that? Well, we know that about somewhere between 30 and 86% of people living with MS will experience pain related to their MS at some point in time during their disease. And we know that about 12% of those will say that pain is their worst symptom that they experience. The other myth that is quite common is that prescription medication is the only effective treatment for MS pain. In fact, more commonly, when I talk with people about managing pain, there is a resistance to look at treatment because the fear is that I will prescribe a opioid medication. So fear of becoming addicted to perhaps a treatment. What we know is that polymodal pain management, so using more than one strategy, is more effective than using one modality alone. And we also know that often the more common medications that people are aware of, such as opioids, aren't commonly used to treat the types of pain we see in MS. And certainly they are not the first modality that we reach for. We also hear quite frequently, or at least I do, that pain that occurs in absence of an acute injury must be caused by MS. And that sometimes is something that an individual themselves believes, or they may be told by another healthcare provider or a caring family member. And often it is important that we assess the cause of pain. Yes, it may be that it is caused by MS, but often pain can be multifactorial. So pain can be caused by an MS lesion, but there can also be some underlying muscle pain, joint pain that can affect mobility, and appropriate management of that can improve quality of life and function. Next slide. So what are the common types of pain we see in MS? So we refer to type of MS pain of chronic neuropathic pain conditions. One is dysesthetic extremity pain. This is the tingling, aching, burning sensations. This generally occurs in the lower extremities, but people can experience this in other places as well, such as their arms, their trunk. And some people will experience this type of pain over their face. And usually it's anywhere between 12 to 30% of folks who have MS will experience this type of pain. The other type of pain that is quite common is paroxysmal pain. That means pain that comes and goes. It may come and go randomly through no provoking action, or it may come on as a result of movement or sitting in a certain position. The most common I can think of to talk about is Lermite's phenomenon. So a shock-like sensation that travels down from the neck, down the back, and possibly into the upper and lower limbs with neck flexion. Up to about 41% of folks do experience this type of pain. And often we can find strategies that can be helpful to manage it. The other type of paroxysmal pain, or pain that comes and goes, that is quite seen quite often, or at least I see it quite often, is trigeminal neuralgia. This is a sudden, severe, stabbing episode of pain, or recurrent episodes of pain. So shocks in the side of the face, either affecting the side of the cheek or along the jawline, that feel like electrical currents running through the tissues. This type of pain can be quite severe. It can wake folks from sleep, and sometimes it is a very short duration of pain, and other times there are recurrences. So it may occur several times in a row, several times a day, and then be dormant or not occurring for a period of time. And often this type of pain does require medication to treat to allow it to become less disruptive to day-to-day functioning. Folks with MS, we know, have more risk of having migraine headaches, and we're beginning to understand that it may be due to actually lesions in certain parts of the brain that can cause this to occur. People who have muscle stiffness or spasticity also can experience pain because the muscles are working in ways that are causing mechanical muscle pain, and also secondary to that can cause some inflammation in the nearby joints, which can then aggravate pain further. Finally, there are some problems with painful spasms that are separate from spasticity pain, where a part of the body will become very tight and stiff, and almost feel like it can't be voluntarily moved. And then that sensation does pass. Fortunately, that is not very common, but can be quite disturbing when it does occur. Next slide. So when we talk about understanding pain or assessing pain, we want to look at all of the features of the pain. So asking what makes it better, what makes it worse, how does it feel, does it come and go, does it persist, is it strong, is it dull, is it sharp, where does it occur most often, and the timing of the pain. Does it occur in the morning, in the afternoon? Does it occur more with activity or more at rest? Does it only occur at nighttime or perhaps just before bed? But then also there are other factors that can actually affect the experience of pain. So we look at the biological factors, so the severity of the disease, any type of local or systemic inflammation that can contribute to the experience of pain. Psychological factors can contribute to the experience of pain, mood or affect, anxiety, problems with high levels of stress or difficulty with coping skills can contribute to pain. Social factors can also change one's experience of pain. Cultural factors, so how people believe pain is to be managed in their particular experience or culture. The social environment, so what is socially acceptable within the family unit or amongst peers. Economic factors, so how much financial support you have to be able to access services for managing pain, but also economic stressors that may be causing increased anxiety or worry in another area can actually contribute to pain. What we know is that when pain occurs, it is affected not just individually by these separate factors, but they all interact together and drive pain. So the sum of the whole is often greater than any one on its own. Next slide. So how do we look at pain management? So holistic pain management looks at the physical, emotional, psychological, and social factors in the pain experience. We look at different treatments, modalities based on the experience of pain, values, beliefs, treatment goals, and access to care. The treatment of pain is individualized, but uses common evidence-informed strategies, things including physical activity, either active, meaning the individual is able to do the activity themselves, or passive in the sense where someone can help with stretching a particular group of muscles or moving an arm or a leg, so doing some passive exercises. Sleep and rest are part of a pain management strategy. Nutrition is also a key part of managing overall health and pain. Having connectedness with the community, with people that are in your life that you identify as important, and having that level of psychological support is also necessary in pain management strategies. We know that pain management, regardless of what I recommend or say, really doesn't matter if it's not accessible. So meaning if you can't get to the exercise class, or you can't afford to go to the specific therapy, then there's no sense in me recommending them. So having an understanding of what is accessible to an individual, so depending on where they live, or what their ability for access to transportation is important. Is it affordable? And also, is it acceptable? Does it meet with the individual's values and goals and their view of what is important in health? Recommendations are just that, recommendations. In order for a successful pain management plan to work, to move things forward and have an improved quality of life, there needs to be overall buy-in and participation from the individual. Next slide. So what's a starting point? So a holistic assessment, so meaning a health history, where if I'm seeing someone for pain management, we talk about their health concerns, any comorbidities that they have. We do a physical assessment of the area or areas that are painful. We look at lifestyle and socioeconomic factors, their values and beliefs related to health and illness, what community supports they have, and also what other stressors they may have. We then move on to look at what they've tried in the past and what they're willing to try in going forward. Specific, measurable, action-oriented, realistic, and time-bound goals are very important. And so with any type of treatment, I talk to folks about that this may be one piece in a larger puzzle, or that a particular measure, such as physiotherapy or exercise or massage or heat therapy, is going to have some effect. But to perhaps expect that one strategy in and of itself is going to be 100% effective and resolve pain after a very short period of time of use, it would be unrealistic. But I think it's important that as an individual who is going to be receiving a type of treatment or therapy, that they understand what the expectation or what the outcome of this may be over time. We'll talk on the next slide a little bit about strategies to meet those goals. Regular check-ins with the healthcare provider, maybe that's by every couple of weeks, or every month, or perhaps less often, to discuss what's working, what isn't working, and also to provide some support and encouragement, because working through and living with pain is a very challenging situation, and having that ability to have support and encouragement is tremendously beneficial. The other important part is to look at a plan for acute flare-ups. And so what happens if one day or for a few days the pain is worse? What can I do that can treat that? And so that should be part of any strategy for managing chronic pain. Next slide. So what are some of the strategies? So we break them up into groups just because that seems to be an easy way to remember and also to kind of look at things a bit more detailed. So some lifestyle factors we already talked about: physical activity, nutrition, so a whole food-based diet. Now, that is a separate lecture all in of its own. Sleep and rest. CBTI for insomnia can be very helpful as a treatment in that area. Having a network of family and friends for support, using spirituality or traditional practices as well is beneficial. And those opportunities can certainly play a significant part in any pain management plan. Using pharmacologics is also often part of pain management, looking at simple analgesics, so medications that are available over the counter, things like supplements, herbs, topical preparations are very often helpful and often very acceptable as a starting point. We can look at prescription medications, and often those are more non-traditional medications that people think of when we think pain management. We also use some Botox for pain management, particularly around spasticity. For specific types of neuropathic pain, localized nerve blocks can be helpful. But also under pharmacologics are traditional medicines. And I think that, having that conversation of what is important with the individual and if there are traditional medicines that is part of their culture that are, reasonable to discuss and consider, then that is on my responsibility as a healthcare provider to become aware of those and help the individual build those into their treatment plan when appropriate. Physical things that can be done: physiotherapy, occupational therapy, massage therapy, heat and cold applications, things that the individual can do at home that are not costing any money or do not require transportation. Using machines like the TENS machine, so some electrical stimulation to some muscle groups can sometimes be very helpful. And there are also good evidence to support the use of acupuncture, yoga, and Tai Chi as part of a pain management program. The other part of pain management involves the emotional space. Mindfulness, breath work has been shown to be very helpful in treatment plans, as well as progressive muscle relaxation. Cognitive behavioral therapy or ACT therapy specific for pain has been shown to be effective as well. And so having a conversation with your healthcare provider about what other options are available to augment and supplement the more traditional paths for pain management is important and can be quite helpful. Next slide. So one of the things that I wasn't aware of myself, and I'm assuming that because I wasn't aware, maybe others aren't aware, is a Canadian-based website called the Power Over Pain Portal. And there are excellent resources there for folks who are suffering with chronic pain, whether it be related to MS or another condition. And the IMPACT program is a program that is based in cognitive behavioral therapy. It is a self-directed program around pain management. And so if you're looking for some resources and support, I think having a look there would be helpful. And also, there are a number of different apps are available. Calm is one of them that I am somewhat familiar with, that look at using meditation and breath work for managing pain. but there are others out there as well, and there are usually free options. Sort of keep looking for what will fit within your expectations and also within your budget. The Power Over Pain portal is free. Next. So I'm just going to skip this in the interest of time. This is just a box breathing exercise. It will be available, I believe, if the slides are available with the presentation, but it is also available on the Power Over Pain portal and the Calm app as well. Next slide. So in closing, chronic pain is common, though the lived experience varies person to person. And that's where, as a healthcare provider, it is up to me to individualize the treatment plan, to ask individuals how their experience of the pain is affecting their lives, and help to find strategies that fit with their goals, beliefs, and values to help them manage pain more effectively. We know that people living with MS are at greater risk of both neuropathic and nociplastic pain, and that all types of pain negatively affect quality of life. We know that caring for the whole person, addressing the biopsychosocial and spiritual domains, is more effective than using any one treatment alone. And finally, most provinces and health regions do have resources available to support individuals in managing pain. Sometimes it can be a bit tricky to find those resources, and that's where MS Canada's Knowledge Network can be helpful to point folks in perhaps the right direction to find those. Next slide. Here are some resources that I often direct people to, and I'm not sure if they can be posted in the chat or online after the talk, but they are commonly available. Next slide. So thank you very much for your attention and for listening to my talk, and I will hand the platform over to the next speaker.
Thanks very much, Trudy. Really interesting stuff there, and I realize there's a lot more options for people than what I had previously thought. We hopefully will have a chance to discuss it a little bit more at the end of our next presentation. Our next expert is Dr. Nader Ghasemlou, or Dr. G. He leads a multidisciplinary research team at Queen's University in Ontario. They're studying the contribution of the cellular and molecular immune response to diseases of the nervous system, and that includes multiple sclerosis. The work is made possible through multiple collaborations with patient partners and clinicians, including the Canadian Chronic Pain Network. Dr. Ghasemlou completed his postdoctoral fellowship in 2014 at Harvard Medical School, where he studied inflammatory and neuropathic pain. He carried out his doctoral studies in neuroimmunology at McGill University. His first research position was as a summer student in the lab of Dr. Jack Antel at the Montreal Neurological Institute from 96 to 97, where he first learned of the damaging consequences of MS. Welcome, Dr. Ghasemlou.
Thank you very much, Shauna. Can you guys hear me? Yeah?
Yes.
All good? All right, great. So I'm just going to wait for my slides to pop up here. There we go. So I'd like to start really by thanking MS Canada for all that they've done in supporting the work that we do. So MS Canada has actually supported the 3 trainees whose work I'm going to be sharing with you today. Julia Siegel, Vina Lee, and Doriana Tacardi have led a lot of the work that we've done in the lab on both the preclinical and the clinical side, looking at pain. And the work that I'm sharing with you has been funded primarily by MS Canada, that works on donations from people living with MS and their families and those who care for them. As well as some of the work that I'll be sharing is coming from a project that we began with the Chronic Pain Network, that is funded by the CIHR's Strategy for Patient-Oriented Research. And I would be remiss to not name some of the people who are really instrumental in getting this work going, who are the lab as well as the collaborators that work with us. And I'll also single out Laura Granger, who's our patient partner, who lends her voice to our work and to help us move it forward. So Trudy already gave a really great background overview of what pain is. But on a molecular and cellular level, which is what my lab is interested in looking at, pain is really complex. And the cells that talk to each other, both within the spinal cord and in the periphery, are key to how we feel and process pain. And what the easiest way that I like to think of pain is what happens out in the periphery, where you have a tissue injury or inflammation, and immune cells will come into the site of injury, and their job is primarily to help repair. But what they end up doing is they also secrete these mediators that will help to carry out their actions of repair. But at the same time, these can have damaging consequences, including pain. In most instances, actually, pain is important. It helps to protect the tissue from damage, like when you get a paper cut, or if you touch a hot stove, it tells you be careful. But in the context of diseases like MS, that pain becomes pathological and can really seriously impact life. So pain, as we know, is an important part of multiple sclerosis. A lot of people live with pain in MS. But there are other factors that are likely linked to the same processes as pain, and these include fatigue, depression, and cognitive dysfunction. So these are all likely working together in the disease process. Now, in the laboratory, in the preclinical setting, we use different ways to look at pain, and one is with animal models of disease. And one of the things that we can tell you is work that's been done here in Canada, again funded by the MS Society, by Brad Kerr's lab at University of Alberta, was one of the first to model pain in the animal model of multiple sclerosis called EAE. And what they found was at the peak of disease, we begin to see a shift in how this pain is observed in the systems level. And what happens is, because the animal can no longer move as well as it could, kind of like what we see in people, the pain response diminishes. And so one of the thoughts has been, maybe there isn't a pain response with the animal models that we use, or maybe it's masked. And so Julia Siegel in my lab worked to identify a new way of looking at the EAE model. And what she used was a lowered form of the disease, a less severe form of the disease, with a lower toxin that's used to initiate the response. And what she ended up finding was that, in fact, these animals do show a pain response at the peak of disease and after, which is very similar to the human condition. A lot of people living with MS will have both acute pain when they are first diagnosed, but also chronic pain later on that lasts for much longer. And we see this in the laboratory as well, both with mechanical pain and with cold pain. Now, that happens, like I said, at the peak of disease, and it keeps going on afterwards as well. One of the things that we've become interested in our laboratory is trying to understand how rhythms of the body might impact both neuroinflammation and pain in this EAE model. And so why study the body's rhythms? Well, circadian rhythms, which are driven by light, are these 12-hour on-off cycles that will modulate basically every system in our body, from genes to cells to things like sleep and eating, are all controlled by our body clock. And this body clock, while it starts in the brain, actually is found in individual cells all over your body. And in fact, one of the first cells that was really clearly characterized in the immune system as having a rhythm is the neutrophil. And so if you've ever woken up in the morning and had little crusties in the corner of your eyes, those are actually dead neutrophils that are the cells that come in to clean all the dirt and debris that we encounter in the environment. But because they can't be cleared by the body normally, they will aggregate in the corners of our eyes, with the tears that we have and then dry up, and that's the cells that we have there. Now, these cells have a rhythm, and they don't only have a rhythm in terms of when they course through our blood, but also what genes they turn on and off, and when they turn these genes on and off. And what we know is that this is true both in the laboratory setting and in people. And so this idea of the nervous and the immune system talking to each other has been known to be really integral to the disease pathology in multiple sclerosis. And we know that circadian rhythms can act on both the nervous and the immune system. And so what my lab is trying to do now is to link all of these together and try to see how circadian rhythms, the nervous system, and the immune system can work together in the context of diseases like multiple sclerosis. So one of the things that we did was using this model, the preclinical model of MS called EAE, we looked at their sleep-wake patterns after the disease was induced. And you can see by that red arrow is when we induce disease in the animal. When we go to see on a daily basis, is there a change in these mice? What we see is that there actually isn't. The sleep-wake cycle of the animal is basically intact. But when we dive deeper into it to see what is happening on a minute-by-minute basis, we actually do begin to see these signatures of rhythmic changes in disease that happens both in the acute stage and in the chronic stage of MS. And what's most important, we think, is that the immune cells that normally do show a rhythm, T cells and monocytes and macrophages in particular, that do have a rhythm at the beginning, lose that rhythm during the course of disease, while other cells that did not have a rhythm will gain a rhythm all of a sudden. And so we want to now understand how is the rhythm of these different immune cells impacting disease outcome in the preclinical setting, and then hopefully to take it to the clinic. Now, what we've discovered in our lab now is that actually the pain that is observed in these animals is actually following a rhythm where there is peak pain in the animal setting at 3 p.m. in the afternoon. Why that's important is because that is halfway through the light cycle of the animal. And so in our laboratories, we have lights turn on at 7 a.m. and off at 7 p.m. And so it's like living at the equator. And when we look at this, we see that there's a rhythm in the mechanical response of the animal, where we poke the foot pad and we look to see how much weight does it take for the animal to go, oh, I feel something. And what we see is that there is, in fact, this change over time when ZT2 is 9 a.m., ZT8 is 3 p.m., ZT14 is 9 p.m., so now the lights are off, and ZT20 is 3 a.m., so it's deep sleep, if you will. But for the animals, it's the reverse, because these are nocturnal animals. And so what we see is the pain sets in, and then the pain goes away. So there's this ebb and flow throughout the course of disease, of MS, of pain. And so we wondered if this is true on a level in the clinic. Is this what we see in people? And there's two very interesting studies that were done. The first was actually done in France by taking healthy control males and putting them into a dimly lit room for about 24 hours and keeping them awake the whole time, and then beginning to measure what their heat sensitivity was every hour on the hour. Now, this was done over the next 36 hours. And what they discovered was that there was a rhythm to how these people felt thermal heat. And so we wondered, is that true in other diseases? And it's been actually shown in diabetic neuropathy and post-herpetic neuralgia, for instance, that there is a rhythm. There is a change in pain outcomes from morning to night in people that have a very well-characterized disease like diabetic neuropathy and post-herpetic neuralgia. Now, we wanted to see this in a more dynamic disease, if you will, and we began with chronic low back pain because so many people live with chronic low back pain. And what we discovered is that we can actually use rhythmicity of pain as a tool to phenotype what a person's response looks like. And what we discovered was that there are basically, if you will, three kinds of pain. There's constant pain, and you can see here in yellow, constant high pain, so a 7 out of 10, if you will, the whole time, every day, 8 a.m., 2 p.m., and 8 p.m. There's a constant low pain at about a 2 or a 3 on 10. There's a rhythmic pain, which starts low and ends high every single day. And then there's another subset of people that have a mixed pain phenotype, which is, if you will, pain flares, like what Trudy was talking about, that happen at random times of day. But when we looked at these people at a more molecular level, what we discovered was that these potential for circadian rhythms could be really important. And there's a change that happens both in the genes and in the systems. And this inflammation can really be linked to the outcomes, especially in diseases like MS. Now, whether circadian rhythms themselves play a role in the preclinical model and in the disease itself in the clinic remains really largely unknown. Now, if we look at what the rate of disease of MS looks like throughout the world, you'll notice that it's actually most prevalent in the northern and the southern poles. And in the equator, those countries at the equator, we don't see as much MS that's happening. Now, there's, of course, a genetic component, as well as likely, we think, potentially a circadian component. Now, why and how do we think this could happen? When we look at the amount of light that we experience, if you're living in, say, Montreal or Calgary, you will see an approximately 8.5-hour shift in daylight hours from the first day of winter to the first day of summer. And in fact, when we look at the United States, we see that there's this exact sort of change happening where the rates of MS within the USA are dependent, almost it seems like, on the latitude at which the person is at. So the daylight hour shift for someone living in Texas or Florida is going to be about 4 hours from the first day of winter to the first day of summer, but it's about 8.5 hours for those of us at the 49th. If you live in even higher climes, like in Edmonton, for instance, you're talking more about a 9-hour or even 9.5-hour shift in your daylight hours. And so this is really changing the circadian rhythmicity of the person, and this could have a profound impact on both the nervous and the immune system. Now, this comes to a chicken and egg question. Is it because of the changes in circadian rhythms that we become more susceptible to MS, or is the MS itself causing a change in the circadian rhythm of the person? And that's what we really do want to figure out. And these fluctuating symptoms in MS have been looked at before by Anna Kratz, for instance, by her group, but they clustered everybody as a whole. They said, well, you have MS, this is what things look like. It looks like your fatigue is going up. It looks like your pain is going up. But depressive symptoms and cognitive problems are basically flatline. We wanted to take a more iterative approach, like what we've done with our chronic low back pain group, and see if that's going on. And so we dived into a data set that we began collecting from a project called Circa Pain, because we had people living with MS that were among our population. And what we found was that we could actually divide the people who took part in our survey into two groups, a rhythmic group and a constant group, in terms of what their pain experience was like. And now what we're doing, that the first edition of the study has closed, is to go in and dive into the data and try to understand what are the potential factors and causes of the rhythmicity and the constant pain outcomes. Now, to take this a step further, we've recently launched the Circa MS study. And Circa MS is found at circams.ca, and it's a study that anybody in Canada or the US can be involved in. And the goal here is to really raise awareness not only about how circadian rhythms are important in MS, which we do through blog posts and other tools that we provide to the community, but also to gather data through our survey to better understand what MS pain looks like, what MS fatigue looks like, and what mood symptoms look like in MS at those 3 different times of day over 10 days. And so if anybody here is interested in taking part in that study and helping us to gather more information, please scan the QR code and find us on the different platforms that we have, where we share the blog posts with people, and data from our study hopefully will be coming out in the next couple of years once we have enough data to see whether there is a rhythm in fatigue, mood symptoms, mood outcomes, and pain in MS, and whether these are linked to any of the biopsychosocial factors that Trudy was talking about, taking this holistic approach to the work that we're doing. So we're really hoping that this can be the next phase of our work, and translating both what we're doing in the laboratory setting to the clinic, with the goal of trying to come up with new strategies to treat the symptoms of MS. Like Trudy had said, we really want to go towards non-pharmacological options, and we think that resetting the circadian clock could be one of those ways to do it, and we want to figure out how and why that could be effective. Yeah. Thank you very much.
Really fascinating. I've learned so much new information here. I'm all excited. I'm probably going to spend the next hour or two online looking this stuff up and signing up for circams.ca. I do have one question specifically for you, Dr. G, and that is the differences in men and women in pain. And I know that some research had been underway at the University of Alberta probably up to 10 years ago. They were starting to look at that. What can you tell us specifically?
So so that's something that our lab is looking at as well. It turns out that, so like Trudy said, women are more likely to experience pain than men. Women are also more likely to be diagnosed with MS than men. The molecular and cellular signatures of chronic pain have been really well studied in neuropathy, using the preclinical models. And what we've discovered now is that there are two distinct cellular systems that are at work in male versus female mice. And so we are taking that same idea, those techniques and discoveries in neuropathic nerve injury models, and applying them to the EAE model of MS to try to understand if the same cellular cues that we see in the spinal cord of a nerve injured animal holds true with MS. But we do know that the pathology is different, and the outcomes that we see in the laboratory are different. In terms of our own studies, the data that we've gathered from Circa Pain and the preliminary data in Circa MS, it's really skewed towards female participants. And so it's hard for us right now to make a distinction of whether or not there are any differences or not in terms of how the pain is processed or how it's experienced. The same holds true for most other studies as well. It's primarily females who take part in the studies than males. So we need more males to sign up and take part in the studies. Yeah.
Well, that's a first. Because normally there's more men involved in these studies than women, but fascinating stuff. I'm also interested in, this is me personally, the just kind of off topic, but you mentioned neutrophils, the leaking from your eyes, the crusty stuff, and I'm thinking, so that crusty stuff in your eye in the morning, that's brain poop, basically. Which is what?
That's eye poop. It's eye poop.
Eye poop. Yeah. Eye poop. Coming from
exactly.
Okay.
Yeah.
Yeah. Okay. These are ways for myself to amuse myself. We don't really have any other questions, but maybe some final thoughts on the type of research that people can participate in. This CCHNC-C thing looks really, really interesting. Maybe a few words on that again.
Yeah. So I'll tell you where the idea came from. When I was doing my postdoctoral fellowship in the U.S., it was in the midst of the opioid pandemic, really, not an epidemic, but a pandemic that was happening in the U.S., where there were instances of people collapsing in shopping centers because they were on opioids, and deaths were through the roof. And when we came back home to Canada to set up our research labs, I said, I really want to try to find a way of a non-opioid tool to help treat pain. And circadian rhythms became a really interesting way of doing that. And it was really by accident that I came upon this, because I went late one night to do an experiment, and I realized that my animals that should have been responding were just not responding at all to any stimulus. And it turned out that there's a response that happens that's caused by this neuroimmune communication that's blocked during the dark phase. And so this really piqued my interest of, can we use this rhythmicity as a way of helping people with pain as well? And so this is the line of area that we've begun to study in my laboratory, and trying to work out the cellular mechanisms and how the clocks are disrupted when we have disease. And when we live in Canada and when you live in Australia, you see these things happen where, why do we have seasonal affective disorder? It's because that happens in the winter months when we're not exposed to light as much as we'd like to be, and so we have that depressed mood. And if you turn on a sad lamp, one of those lamps that will reset your clock, you can actually reset your mood. Why can't it be for people living with chronic diseases as well? We actually just got funding to do a clinical trial for chronic low back pain with bright light therapy as a way of resetting the circadian clock in people. And we are using now an at-home blood collection kit to try to timestamp what the gene signature is like for each person in their immune system over the course of the day, as a way of better understanding how there's a shift as the day progresses into night, and whether this has an impact on the changes in pain. Fatigue is really important in MS, and there are a lot of shifts in fatigue throughout the day that we see that are really important in multiple sclerosis. The same goes with depressive mood as well. And so linking all of these together and thinking of it at a cellular and molecular level, I think, is really important. And like what Trudy said, right? It's this holistic model of the person. And so we take that holistic model a step further and say, let's not just think of the person as a whole, but at the cellular level, and the individual cells and how they talk to each other, and how the time of day may be affecting that communication between the cells. And could this be what's impacting the disease? And so we hope that Circa MS will be one of those tools that will give us insight into what are the impact of the medications that people are taking to treat their MS on their rhythmicity. What are the impacts of those who have pre-existing conditions on this rhythmicity, and how can we better understand what's happening to the individual to better understand the disease itself, and hopefully to help others in the future.
And perhaps looking at timing of the treatment as well.
So pharmacotherapy is a big one, and I'm sure that it's something that a lot of people think about is, why do I take my meds in the morning at the same time when my pain gets worse or my fatigue gets worse in the afternoon? Should I be taking it later? And I'm sure that that's something that Trudy can speak to of what is the impact of the timing. We say in the morning because it's easy, right? You wake up in the morning, you take your medication. But what if it's better to take in the afternoon or in the evening? Some drugs we know are more effective at night than they are in the day. And so the same may be true for drugs that impact a specific outcome or symptom of MS.
Wow. Okay, well, we've come to the end of our session, and I'm fascinated with all of this information. As Trudy knows, I'm a bit of an information geek, so I love all this stuff. As I mentioned, I'm going down a rabbit hole tonight later. Trudy, thank you for all that information as well, all the different options that are out there in treating pain in folks with MS, a lot more that I hadn't even considered before, so thank you for that. As we wrap up today's broadcast, we want to remind everybody about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time, and they can provide assistance in both English and in French. We want you to be part of the MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. Together we can take action to create a future free of MS. To find out how you can take action, check out our website at mscanada.ca. If you have questions about any of our education activities, you can reach out to the education team by email at education@mscanada.ca. On behalf of MS Canada, thank you for tuning in for today's webinar. Good night.